Diabetic neuropathy. Diabetic neuropathy can be sensory neuropathy, motor neuropathy, autonomic neuropathy. The sensory neuropathy includes insensate food, that means the sensation of touch, pain are either diminished or lost. Loss of protective sensation, loss of position sense and vibration sense. Motor neuropathy leads to muscular weakness of the lower limbs and the muscles of the feet. There could be foot drop and deformities of the feet develop due to motor paralysis and motor neuropathy. Autonomic neuropathy, of course, poor blood flow regulation to the feet, skin becomes dry and the skin becomes stiff. This increases the chances for ulceration. The pathogenesis of diabetic neuropathy is the vasa nervorum is affected. The vessels supplying the nerves are compromised. It is a microvascular complication. Associated problems of diabetes like retinopathy and aging worsen the problem. Depression and peripheral arterial disease further contribute to the bad effects of neuropathy. The other important area is the lack of adequate self-foot care. How many of our patients, or in fact we ourselves, we examine our feet often. Patient education is inadequate. Patients are not motivated to keep their feet clean and also observe the feet regularly. Depression associated with diabetes and old age and anxiety, they will add to the problem. Anger is more common in diabetic patients, and there will be adequate foot care will be neglected. Comorbidities like coronary artery disease, CKD, these will add on to the problem. Of course, the advancing age and the physical disability associated with age make them less careful about their feet, and they may not be able to see because of diabetic retinopathy, or majority of the patients because of obesity, they might not have the ability to look at their feet. 50% of the people who are aged and obese, they cannot look at their feet unless somebody examines their feet or they use a mirror to examine the undersurface of the feet. And of course, in our country, in many countries also, the podiatry services are very limited for access, and this makes the foot care much more worse. So, all that is most important and to be emphasized is that patient education and patient motivation have to be given importance, and see that adequate self-foot care is practiced by all diabetic patients, so that they can report even minor injuries and minor changes in the feet like discoloration, erythema or dryness to the doctor, and we can take corrective actions in a very early stage. Sensory neuropathy in diabetes causes loss of protective sensation in the feet. Sensory loss is sufficient to allow painless skin injury. It need not be total absence of sensation. Even if it is diminished, the pain perception is less, so the skin injury occurs without the knowledge of the patient. This is the major risk factor for foot ulcer formation in diabetics. Detect this using Semesvistin monofilament, 10 gram monofilament. What is this monofilament? How to use it? We will see in the subsequent slides. Prevalence of insensate fit to 10 gram monofilament is of this order. Age more than 40, 30% of diabetic patients, the feet are insensate. If the age is more than 60, 50% of the diabetic patients, they are insensate to 10 gram monofilament. Up to 50% have neuropathic symptoms associated with insensate fit. Majority of the diabetic patients, they may not complain any symptoms of neuropathy, but if you test the neuropathy, they will have the insensate feet to the tune of 30 to 50%, depending on the age that is listed here. Earlier, we were using cotton wisp, the bristle brush or a pinprick to test the sensation. Now, internationally, this monofilament, which is called the 10 gram monofilament, 5.07 10 gram monofilament or Simon-Wilson monofilament is the one that is recommended for testing, and this has been standardized all the world over. It will have a small nylon filament there. As you can see, different versions or forms of this are available commercially, as well as one can obtain from the American Diabetic Association by asking them to supply you a set of these monofilaments over the web. If you order, they will supply. So, how the foot is tested? Just to hold the monofilament perpendicular to the foot and then gently apply the tip of the monofilament onto the foot and then try and bend this, and this bending force should be such that it gives a 10 gram force onto the foot, and that should be appreciated normally by any patient. So, this is what is called the 10 gram monofilament testing. The subsequent slide we will see some more details about this. The details of using this 10 gram monofilament have been supplied to you in the handout. Kindly go through those things. Very simple explanation. It's easy to use. The areas to be tested are marked here in this chart. So, these are the three areas: the first metatarsal head and the third and the fifth. Three areas are to be tested, and of course, the ball of the grade 2, of course, on both the feet. Demonstrate sensation on the forearm or the hand to start with using the monofilament. Patient should understand what you are trying to test and how it feels like. Then place the monofilament perpendicular to the site of testing, let us say here, and then bow the monofilament into a C shape for 1 second and test 4 sides. These are the 4 sides on each foot, and this is predictive, 95% predictive of insensate feet. Heel testing is not helpful. There is no need to test this part of the foot, and this is not going to differentiate insensate feet from normal feet. Avoid places of ulcers or scars or calluses, because in those areas you cannot get accurate interpretation of the test result. How good is this 10 gram monofilament testing? Predicted ulcer or amputation in 5 prospective studies. The results are so like this. Negative predictive value, that means if the patient is able to sense normally, it has predicted ulcer and amputation in 90 to 98% of the patients. That means if a patient is able to appreciate the monofilament, the chances of he having an ulcer or amputation are as low as 2% to 10%. The positive predictive value, that is, if the patient fails to sensate, the positive predictive value of such a test result is up to 36% of them, they end up in ulcers or amputations. It's amazing, a simple test gives such a good negative predictive value, rules out high risk feet, and also the positive predictive value, a good test, this test confirms in around 1/3 of the patients that they may develop an ulcer which can go on to amputation. Prospective study done over 32 months of observation, 80% of the ulcers and 100% of the amputations, they have insensate feet. Superior predictive value to all the other tests like using a pinprick or a cotton wisp or bristle brush, or using the patient's symptoms. Depending on any one of these things, the predictive values are not that high, but using the monofilament, we could get a good very high negative predictive value, a reasonably good positive predictive value. Of course, testing vibration sense using 128 megahertz tuning fork is also recommended, particularly with the American Diabetic Association. Not only the touch sensation, the vibration sense also is important. To test the tuning fork vibration sense, vibrate the 128 tuning fork, keep it on the tip of the great toe. the patient should experience the vibration. Of course, you must demonstrate to the patient how the vibration looks like on his arm, forearm, or on the elbow, and then put it on the foot. The International Working Group on Diabetic Foot have classified the risk profile as follows. The IWGDF, International Working Group Diabetic Foot Classification, Category 0, no diabetic peripheral neuropathy, frequency of examination required is once in a year. If the patient has got Category 1, that is sensory neuropathy present, monofilament testing yielded a positive result, that means the patient is not able to appreciate the sensation, then it is mandatory we test the feet every 6 months and ask the patient and educate the patient to closely observe his feet every day, because he has already got sensory neuropathy. Supposing the patient has got sensory neuropathy, diabetic sensory neuropathy, and also a peripheral arterial disease or a foot deformity, he falls into Category 2, and such patients it is mandatory to examine every 3 months for the sensation and for the vascularity and for the foot problems. And of course, the patient has got a history of previous ulcer, automatically he falls into Category 3, and in such patients once in every month foot examination must be done by the physician, and the patient should be educated to inspect his feet as often as possible. A scoring has been developed for diabetic neuropathy. This is called Neuropathy Disability Score in Diabetes Mellitus. Here we use other sensations like the vibration, the temperature, the pinprick, and the ankle jerk, and combine these scores to form a summary score. Vibration threshold at 128 MHz tuning fork, if it is normal, score is 0, if it is absent, the score is 1. Temperature perception, tuning fork is dipped in hot or cold water in a beaker, not very hot water of course, and then that base of the tuning fork is applied to the foot, and the patient perceives the temperature sensation of cold or heat. Normal is 0, absent is 1. Pinprick, and the pinprick has to be given small prick with a pin proximal to the toenail, just to depress the skin, not to injure the foot. It is normal when there is pinprick is felt, that score is 0, and when it is absent, the score is 1. So then why ankle jerk? Ankle jerk is to the afferent reflex arc of the ankle jerk is a sensory component, and that is being tested here. Tendo-Achilles reflex, if it is present, then it is score is 0. If it is present with reinforcement, then it is present, the score is 2, and if the ankle jerk is absent, the score is 2. Okay, so a patient can have all zeros, which means the score can be 0, or he can have scores any one of these areas 1 plus 1 plus 1 plus 1 or 2, total maximum to be 5. So the total score for each foot can be anywhere between 0 to 5. For one foot, for both the feet it will be 0 to 10. If the total score is more than 6, it is predictive of diabetic foot ulcer. So this is another way of looking at diabetic foot sensations other than using monofilament as has been already explained. So it is better that we do both the monofilament as well as the neuropathy disability score and classify the patients for their risk status as far as the diabetic foot risk is concerned.